Hello everybody. Today it will be the lecture 1, what we will record from nowadays in IDSC. So you can follow our channel. It will be full of information about dental implantology and many things in this channel. So please, this is for just dentists and who like to do some implant or who like to be implantology. So from today we will start to record each lecture for Dr. Suhail Hosseini. So I hope you will enjoy it and you will enjoy the channel. Follow us and subscribe. Give us like for each video. We hope to see you every time. Thank you very much.
The osseointegration, say intaglio surface. Maybe you don't, you know the word intaglio, what does it mean? See, you know intaglio, you know intaglio, you know intaglio. People who don't know what's intaglio surface, raise your hand. Okay.
Although I read it before the
So if you had the chance to change this word to another word which actually is easy to remember and say, and so take dentistry, to be more specific, take implant dentistry, and imagine you had the right to change the known name to a better, easier, simpler word, and everybody will follow you. Can you imagine? So for today, I invented another word for biological width. Okay, now you go know by the background. So now I can say biological for implants, not for teeth. Gorgiello, 1961, he said biologic width, and it became a known thing. I'm saying for implant, let's not call it biologic width. Why? Because the 1.7 millimeter, 1.07 millimeter does not apply. Why to keep saying with implants biologic width when it's not 1.07 millimeter? Let's call it biologic height. Then it makes difference. What today Dr. Khaled is going to show you is biological height. And hopefully we will understand how we create a biological height. You think it's a better word? Yes. For implant, not for teeth, than biologic width, which is not fixed.
Mastering the emergence profile, enhancing soft tissue integration and implant aesthetics. So let's see who first spoke, pioneers who spoke about the emergence profile. In 1981, it was Schroeder, the first one who mentioned the importance of soft tissue around implants. Then Brainmark in 1983, he focused on osteointegration and implant design, and the subsequent studies later on, it was about aesthetics and soft tissue management. In the 19s, these Lang and his colleagues, how they set the understanding of how emergence profile impacts long-term soft tissue health and aesthetics. Basically, in the 2000, Gonzalez is the first one who mentioned the word emergence profile in his research, in his papers. So, and we can see the 3 layers Dr. Suhail told us about in many lectures. So this is the first layer, which is the deepest one, which is CT, connective tissue. And then we have the upper band in the middle, it's junctional epithelium. And we have the third one, which is next to the bacteria and to the oral cavity, which is circular epithelium. The most epithelialized layer would be here, which is our guard. So what is the emergence profile? It's defined as the three-dimensional contour of implant restoration extending from the implant abutment to the surrounding soft tissue. So this space here is called the emergence profile. This soft tissue here is called the emergence profile. This profile affects the tissue behavior around the implant, influencing both aesthetics and function, especially aesthetics in the anterior area, in the aesthetic area, in the maxillary. So the visibility of the implant restoration can be significant impact, and I think patients are now very demanding. They want the same soft tissue level and this central on the central. So we have to focus on this soft tissue, especially in the anterior maxillary. You can see the connective tissue, junctional epithelium, and circular epithelium. The thing is, we always wanted the composite not to be here in this. This is only for abutment. So if you have like 4 mm of soft tissue thickness from the implant neck to the free gingival margin, you will make a space for your abutment, and the rest will be composite. We will not go deep with the composite to the neck of the implant. So what are the key factors affecting emergence profile? The first and most important one is the 3D positioning of the implant. Because if we place an implant that's too much angulated, same as usually it happens with the anterior maxillary because of the angulation of the bone, so we had to angulate our implant in unfavorable position. This will lead to a thin soft tissue here, thin soft tissue biotype, and this will make your emergence profile less, let's say, less beautiful, because you don't have that much of the soft tissue to manipulate. Then you will have to do some soft tissue augmentation, free gingival, connective tissue from the palate. So implant, of course, we know the rule 1.5 from implant to tooth, 3 mm between two implants, because you need to leave space for the gum. If the implant is too close, like 0.5 mm to the tooth, then you will lose the papilla. The papilla will go down. The second one is the implant neck design. So as we spoke about, Dr. Suhail called it the top box implant, the implant that comes with a very box neck, and there is no platform switching here, you see, so there is no space for the soft tissue. So once we move on to a soft tissue platform switching, you have a space. So you see, when you place a wider implant and a less diameter abutment, which is you see this space here is getting bigger. So once we have a wider implant, we have more chance to have a space for our soft tissue. So this is very important in emergence profile. Soft tissue quality, as we said, we have thick biotype and thin biotype. If you have a thin biotype and you want the emergence profile to be better, you'll have to do a soft tissue augmentation. Abutment type. There are many types of abutments. The stock abutment that our companies usually give us, they're custom. They're stock abutments. So they're no shape. They're in like this is the dimensions we have. You put it. That's you get. So the soft tissue will adapt to the abutment. You see, while the anatomic abutment or the custom abutment will adapt to the soft tissue. We don't want the soft tissue to adapt to the abutment. So the custom abutment will follow the gum contour. The restorative angle. What's the restorative angle? As we said, the platform switching, our abutment is going up. So if you go with a wider abutment, you see, you're taking the space of the soft tissue. So you always have to leave space here because soft tissue will have to go there. So this is the restorative angulation. So always with a wider implant, we try not to put too much wide abutment because we want to leave space for soft tissue. So what a well-designed emergence profile will give us? It will give us proper soft tissue integration, and we know it's very important for the long-term stability of the implant. It will mimic natural tooth contour. You can see here without any bone augmentation or soft tissue. This is without any soft tissue, just a proper handling of the implant position and the temporary. we give us the natural looking, mimics the natural tooth contour. This is mimics the neck of the lateral. Prevention of peri-implantitis, as we all know, once we have, as Dr. Suhail told us, we need 2 millimeter of buccal bone and we need 2 millimeter of keratinized buccal soft tissue. Long-term aesthetics outcome, of course, this will last for a long time. So companies have been giving us many choices. So they want to follow the gum, follow the soft tissue. So that when you remove the healing abutment, you will find that your molar bed is ready for your molar. If you're removing a central, your central bed is ready for your crown. So like Emergence, they have anatomic healing abutments. So for each site in the mouth, they have a special healing abutment. But anyway, this one is also not customized because the dimensions is stable. It's not fitting for it. I mean, some patients will come with 8 mm molar and some will come with 11. You see, we have the Anatotemp, which is an anatomic healing abutment plus scan body. We have iPhysio we're using. It's 3-in-1. It's a temporary abutment. You can remove this screw, and there is a shorter screw. Will go down, so it leave a space here for your temporary crown to fit in. And it's a scan body, and it's anatomical healing. BioHorizon, they have the Smart Shape Healer, also the same principle. So you see all of this. I mean, iPhysio is very good, but if you're extracting, you want to place immediate gingival healing on a molar site, which is 8 or 9 millimeter. The biggest iPhysio C would come around 7 or 8 maybe. So there will be some space around the abutment, about the healing abutment. So we come to the cervical VBI, which is a customized kit that will give you will customize your healing abutment for each site you have. So if you have 6.5, you will put a healing abutment of 6.5. It's not 5, it's not 7. So, and it comes also the socket healing abutment, which is SSA. It's very good also because you customize the socket. So you extract the first molar and you see the big cavity defect on the buccal wall. So you see the concavity of the soft tissue after extraction. You can see that we lost the buccal wall. So with SSA, socket sealing abutment, from its name, it should seal the socket. So once we did, as I said, the implants should be in the perfect 3D position because you want the screw to be in the middle of your restoration. And then you can build up, of course, you need primary stability. To put this immediate, you need primary stability. And then you put the abutment, you try to build the composite just to mimic the first tooth, the natural tooth. And then you take it out of the mouth and then you fill all these spaces with composite, you polish from inside. It should be too much polish from the inside, okay? The one that's facing the soft tissue down. And then we can place some bone graft and then we can fit it. It would fit and it will give you a nice, you will go home and you will, I did something good. Because you're hiding everything here. I mean, you're sealing everything down. Nothing is exposed. And the patient the patient after the surgery, he will feel probably nothing. Maybe the patient will take 1 painkiller or 2. So let's talk about cervical VBI. There's so many confusion of the coding of the, so there's 2 M. There's M1 and M2. M1 is a square-shaped molars, which are the lowers, which is this one, M1. These one, M1, M1, M1. You have 3 M1. M1 is for the lower molars because it's a square, while the upper is elongated shape molars, M2. So if we have M2, this is upper molar. The L, large, M, medium, S, small. C is centered position, and O is offset position. So if you placed your implant in the center of your socket, in the center of your future crown, you will pick the C. If you had to go palatal to surround your implant with bone, then you go to offset position. Okay, this is a depth gauge. You can put it on, you know, how much you have soft tissue. So the evaluation of mesiodistal dimension, the rounded one here, this inside circle, is to see the mesiodistal. It's not to make the outer circle is to make the temporary, but the inner circle is to measure the mesiodistal. So you have, like you see, and each one there's a number here, 5, 6, 7. So if you have like 7 is fitting, it's giving you here what are the implant diameter you can go. So if you have 10, the least one is 3. You can go with 3. Of course, we're not placing 3 for 10 mm. And the most one is 7. The biggest size you can go is 7 because you need 1.5. And so 10 minus 3, which is 1.5, 1.5, it would be 7. So this number is the diameter of the implant, the minimum and the maximum. And we come then to we have to pick the exact size of the same dimension of buccolingual to the one of the crown to be placed. So if we're placing premolar and you have a second premolar, just try to fit one that's matched this cervical line of this second premolar, because you want this will be your future crown neck going up from the implant. And you have also anterior premolar, anterior A premolar, M1 as I told you, square molars, and M2 for the upper is elongated molars. S is small, M medium, L is large. 12 by 9, it will give you dimension how much space you have here. So this one is 12 and mesiodistal is 9. So if you have a thick biotype and thin biotype, for thick soft tissue biotype, you can go with large, okay? Because you know I have thick soft tissue, it will not fail in your hands. But if you have a thin biotype, then you need more space for the soft tissue. Then you go with medium or maybe with a small. So the first one that I told you to measure the mesiodistal, it could help you in doing your pilot drill, because you can see where is the center of the implant you want. You see, this is the center of your crown. It should be on the functional cusp of the lower premolar. So the ideal that one best fit being the light contact with the adjacent teeth. So this one should not go loose and should not go tight. Okay, it should fit. And then we come to this is that will mimics your neck of your future crown. Either is centered or off-centered. So we measured the mesiodistal, and we know we have 7 mm. We bring this one. We try to find one that will fit our future crown neck. So this is the one we picked. And then we go to the silicone we have, and we search for the same code. We find it like this one. So we bring our abutment. We can connect it with the analog, and we can put it inside till it comes to the line between the analog and the abutment, because this is the line we want the composite will start with. So we'll pour some composite. If it's a big space, it's better to light cure in layers. So you will make sure that all the layers are cured, and you can move the silicone. This is silicone. You can move it a little bit with your fingers. It will remove any bubbles. And then when we finish, we can take it out. You can polish as I told you, the inside area of this should be very polished. And then we can install it, and we can see if clinically and radiographically proper fit with the implant. We can fill the screw as we always do with the Teflon, and we can close it with composite. When the patient comes after 2 months, we can take it out, and you can really see how much the soft tissue give you a nice contour. So this is one case by Dr. Alberto, drilling through the root and using of the cervical. So we have a remaining roots with the periapical granulation. So the planning is the most important thing. This is the perfect 3D position of the implant between the roots, and you see the subcrystal position. He started with the drill between the roots. He took X-ray to see the direction, the angulation of the implant. Then we remove the roots and we insert the implant in the bifurcation, 5 by 10. We get primary stability. This is included in the kit. You see this is 4 mm from the implant neck to the free gingival margin. I think we should. Just wanted to show you how we divided the. Sorry, we have to see it again. So, mucosa height, biological width, this is biological implant dimension. In the best 3D position of the implant. So we measured 5 mm from the free gingival margin to the implant neck. So he divided these 4 to 2 by 2. 2 for the abutment and 2 for the temporary composite we're doing. See, 2 for 2. 2 for the abutment, 2 for the composite. Okay, 4 from implant platform to free gingival margin. This is blue M gel. And then he find the best fit and he do it on outside, polish and put it there. He called this clot chamber. Here will be filled with blood and it will be stabilized by the temporary. This is 4 days post-op. Can you imagine this is 4 days post-op? Look at the gum contour. So 30 days, you can see there is some precision after 30 days. 4 days, 30 days. "60 days, you see the maturation of the soft tissue. You can see the levels. After 60 days, the healing. The thing is, if we're placing the implants after extraction, if we're placing a shallow placement, you will not get this soft tissue thickness. You will have to go deep. This is plaque control area, which is the third session. Transitional area, which is the epithelial sulcus, and this is connective band, which is the connective. Connective band area, support area, transitional between the implant neck and the oral cavity. And this is conditioning area, cervical plaque control area. Here are the most plaque accumulation would be in this area. Any questions?
Just regarding the insertion of the implant, he started drilling before removing the roots. So what the purpose for this?
The most important thing, it will give you a guide to the perfect 3D position of the implant. If you find that you can do it, you can go for it. If you don't want if you're too worried about the infection, fracture of the root, you can remove the roots, and then you will have a hard time placing because this interproximal bone is very thin, so you have to control your drill to drill exactly in it. While if you keep the 2 roots, it will guide you to go between them.
Question. One second. Even the mic.
Yes, 1 second.
Yeah, one question. Maybe it's not clear. Dr. Ahmed is doing a great job. Please support him.
Yeah, sure.
The
One question, doctor. In what situation do we need to do soft tissue graft on the crest?
Soft tissue graft,
Graft on the crest to gain this 4 millimeter. Is there any specific situation or specific
You mean
scenario?
immediate implant, you have a tooth and you want to extract?
No, not necessarily immediate placement, even if it's delayed.
So many techniques to gain soft tissue around implants in the exposure. So if you have to expose, like let's say anterior maxillary implant, and you have not sufficient soft tissue, we had three techniques in the consensus. You remember? We can go with the pedal. We can grab the soft tissue and push it to the buccal. We can do either connective tissue graft, or if you're less attached, you can go take a free gingival graft.
My question is, when do we need to do those?
When you find less than 2 millimeter, we need 2 millimeter of attached soft tissue around implants.
Do you mean before placing the implant, or this is the question?
I would prefer after. I would prefer after.
I want to ask, I was reading about the 1 unit, ما بعرف إذا عم أقول اسمها صح, 1 unit implant, يعني when the implant comes with the abutment. I want to know what's the disadvantage of the 1 unit implant, and in this case we don't use anything for the gum, right? For this space, because it's already there.
Because you cannot do anything. With 1 unit, you have everything there. You have the abutment so you cannot control the abutment.
So it's already there.
It's already there. So you have to put it. You have to place your crown, cement it, and then you don't know after maintenance is very hard because there is nothing to do. There is no abutment to unscrew. It could be, but I mean you cannot unscrew the abutment. It's only 1 unit. So any complications you have, it's really hard to deal with it. So that's why we're not using it anymore.
Finished?
That's it. Thank you. Yes. We still have one question.
Okay, so the analog is this part.
The implant. This is the implant.
Yeah. What we are going to see now
yes,
for
yes.
the analog, it's going to be here, and the start of the composite part is going to be here also from here?
No.
It's going to be from up here?
Yeah. That's right.
Okay, so how do we control this area? Is this area already built in the silicone?
No. If you did extraction and you find 4 mm, you measure and you find 4 mm, you bring your abutment with a cuff height of 1.5. Your abutment, cuff height 1.5. You attach it to analog, you sink it in till the abutment cuff height, not down. So you already have cuff height down and your composite will start up.
I want to add one point here. Where is your microphone?
Yeah, sorry.
All right. So there is no magic number in this kit which is standard for every implant you place. What I'm trying to say is, if you place your implant 3 millimeter below the bone level, the way you're going to handle this is different than if you place your implant at the bone level or according to what he is teaching us today, which is 0.75 to 1 millimeter below the bone level. So in case you go deeper, you have to play this differently. So this is not, I'll make it simpler. What we learned in the last consensus on Sunday is leave 1.5 millimeter of safety zone and then start your emergence profile. Okay? So you say, okay, I will count 1.5 millimeter from my analog and I will start building this for all my cases. No. If you put your implant 7 millimeter deep, then how are you going to do 1.5? 1.5, you're still 4.5 below the bone level. So, depends if you do your homework and you calculate your implant was 0.75 or 1 millimeter below the bone, then you keep that 1 millimeter plus 1.5, then you start building your emergence profile. So the neighboring bone should not be touched. The neighboring bone at the neck of the implant should not be touched by your temporary restoration, which is the composite you're going to use. So if, imagine, for some reason, you're putting your implant, got stuck, and you're above the bone 0.5 millimeter. You're afraid if you go more, you're going to break something. You want to remove the implant, it's not coming out. So you decide to close your compass, you know, your ethical compass. What's ethical compass? Wait, let her say, what's your ethical compass? What's your ethical moral compass? She doesn't, you don't okay, anyway, you decide to stop. 0.5 millimeter above the bone, So what do you do with this kit now? You don't go 1.5 millimeter above this. You're already 0.5 millimeter above it. Just one. So you have to know where you put the implant based on the neighboring bone. Then you can apply the 1.5 millimeter rule according to this kit.
Yeah, so you see this circle inside, these are for diagnosis and you can use them in surgery also. You see? So you pick like 10, this is 10 mm, and you try to fit. It's not fitting, so it's not 10. Let's go like 8. 8 is fitting, okay? This will give you the mesiodistal space between the two teeth. It will give you like an indication what's the biggest diameter you can go. So if you have 8, you're gonna remove 1.5 from each tooth, so your remaining is 5. Of course, you need buccolingual space also to keep 2 millimeter of buccal bone. So you can go for 4.5. And in the surgery, you can stabilize this one and you can drill through the hole. Okay? It will give you indication that you're in the middle of your. These four, the green, purple, yellow, and what is this? Maybe blue. This is the green is the smallest one. So you first drill and then you fit it inside. It will give you a guide that it will go here, inside this one. So once you make the osteotomy, this is the bigger one, the purple. You go with the next drill, so you can, with each drill, make sure that you're in the middle, okay? So if you're wondering what are these four are used for, in the middle, okay? So you can check that you're drilling in the middle. So this is with the inner circle. The outer circle is the one we're doing the temporary abutment. So let's say we have this implant, you see here. When you finish placement, and then you move on to the restoration. You go with this one, which will measure how much you have of soft tissue. It has a marking, so you go deep till you touch the implant neck, and you see what's the number on the free gingival margin. It's 4. So then you have 4. This 4 millimeter you have to make. Okay, you have to go deep. You have to make a biological height. Okay, so you need to go 4, and we have 4. So now you keep it in mind that you have 4 mm from the free gingival margin to the implant neck. Then we want to search for the best fit of the implant. We said M1 is for lower molars, M2 for upper molars. So we go M2. M2 medium. This is M2 medium. Okay, we take it. Let's pretend it's inside the mouth. So I have to go from the anterior, and you see, is it fitting? It should not be loose. It should not be too much tight. This is medium, and you have to imagine that your tooth is like this. Let's try the large. You see the large, it looks too much big. It will not fit. You see on the buckle, it's too much bulky. So let's go with the medium. So medium is fitting good. So we pick one is one M2M, which is M2 for upper molars and M for medium size. Then we have 4 mm, so we bring our abutment and we check. You have to pick the abutment that has a cuff height. You don't go with the lowest cuff height. You don't want 0.5 cuff height. So this one, let's say this one is, I think is 2 mm cuff height. Yeah, this is 2 mm cuff height. So I pick my abutment, which is 2 mm, because I have 4. Okay, then I will connect the analog. I will tighten the screw. Can you give me an analog? Yeah. So we're gonna fit it to the analog and we can tighten it. So we have the abutment and the analog tightened, and we have the right choice of the abutment, which is 2 mm cuff height. Then we go to the silicone and we choose M2M. So M2M, we go to M2M. This is M2MC center. Okay. Then you go down, you push analog till the cuff height disappear, not the analog. Okay, you want the composite to start from the cuff height, so you keep pushing it till the cuff height at the level of the silicone. You can check with this one. You see the cuff height is at the level of the silicone, because this is where you want your composite to start. Okay, down you're gonna pour some composite. As I told you, if it's too much big, you can do it in layers. You can do the silicone like this, just to you can do like this to make sure there's no bubbles. Light cure. So I did the first layer. I will do a second one. Of course, you can put a transfer here, and you can make it with the impression. If you're doing a manual impression, you can put a transfer and you can put composite on it, and you can take impression with it. It will go to the lab, so the lab will have the exact dimension of the emergence profile you have. So second layer. Then you take it out. either with unscrewing it or with pushing it from here. You see some composite is still not cured. Let's pretend I did a good job and it's fully cured. So you have this shape, you see. You see the composite is not down at the implant neck, it's 2 millimeters up because I sink it in till the cuff height disappeared. Then we go, place it in. And we tighten the screw. So you see, if you have a long abutment, you have to cut it. You can add some composite. If you're not happy with the thing you have, you can add some composite here, like this. You can fill all the spaces. Because you want your healing abutment to seal the socket. I prefer not to place bone graft at the end. هلا يعني قبل هي هلا بس خلص انا هي بكون حاط انا سبونج بشيل الهي بالاخير
مونوجراف
بتسكر عليها بهي بتكون هي خلصنا خلاص يعني ما لسه تعمل عليها تعديل تعمل بولشينج خلاص بتخلص كل شيء. With a bar you can polish this one here, you can do more polishing here till you see that your temporary abutment is ready. Put bone graft and put it on it. So as a conclusion, we can say if we have to have this kind of soft tissue emergence profile, the implant should be in the perfect 3D position, especially in the vertical dimension. You have to go deep, at least 4 millimeters, to have this kind of soft tissue around your implant. And then you will go to the cervical VBI. You can reconstruct your temporary abutment to get this kind of soft tissue around your implant. Thank you.
Thank you.